Hello, welcome y'all. So we're back with our best basic metabolic panel lecture. Uh, the last video we talked about glucose level. So the next electrolyte that we're going to be talking about tonight would be the calcium levels. So before I go any further, if you are interested in this kind of videos, please, if you have a chance, to subscribe. And I think it's in my left side of the film that I'm doing. And when you subscribe, you will be updated on new videos that I'm gonna be uploaded in this website or in this YouTube channel. So let's begin. We're going to talk about the calcium levels. Okay, so let's start. Now, so when we talk about calcium level, we talk about the serum calcium levels. And when we look at our chemistry 7 or basic metabolic panel, what you're going to see is an outcome or a result that is related to serum calcium levels. Now, the serum calcium that you're going to be encountering or seeing in your chemistry 7 would be the total calcium level. Now, as I've mentioned in my previous video, the numbers or the normal values that I'm going to be using here are those normal values that I see in the clinical setting. Remember, again, there are different hospital settings that would have different normal ranges. So I want everybody to really focus on what the hospital policy, where you're training or where you're working. Now, I have two numbers here. One is measured in milligrams per deciliter, and the other one is measured in milliequivalents per liter. So these are the normal ranges that you're going to see in the clinical setting. So there are actually three types of calcium that we see in our body. One that is ionized calcium. The other one, those calcium that are found in minerals, we call them the anions. And of course, those calcium that are found in proteins, specifically albumin. Now, most of the calcium level are bound to protein at least 40% of the time, which really makes it difficult to have this total calcium level in the blood, this one that we see all the time in our chemistry 7. So that's the thing about the nursing makes sense. I want to emphasize that they are bound to calcium. So this particular bullet point here, this is what really is the one that really makes sense when you look at calcium level. It's better to look at the ionized calcium because it can provide us with better functional assessment of the levels of calcium in the body. So there are a couple of modulators, or what do you call kind of helpers in terms of calcium's electrolytes in our body. One is the parathyroid hormone, which actually increases calcium level. The vitamin D, of course, that we take increases the calcium level, whereas on the contrary, calcitonin is actually the one that decreases calcium levels. So let's begin with the decreased level in calcium, and we call it hypocalcemia, right? Hypo means lower, so anything below the normal range we're going to consider as hypocalcemia. So what are the factors, or we can call it the causes of hypocalcemia? There are three things that I could think about, and again, this is where the nursing that makes sense. These are the common things that you're going to see or you're going to encounter in the clinical setting as a nursing student and at the same time as a nurse. So three common factors, or three common causes of hypocalcemia. One is decreased calcium absorption. The other one is calcium excretion, wherein there is increased calcium excretion. That's the reason why there is decrease or hypocalcemia in the blood. And then there is decreased level of ionized calcium, and we're going to talk about each of them. So when we talk about decreased calcium absorption, what we're really talking about is the insufficient or inadequate amount of calcium intake that we're going to have. Other factors or other causes would be malabsorption syndrome, such as Crohn's disease, and some other pathologic conditions such as end-stage renal failure. In terms of increased calcium excretion, we will see that in excretion in the kidneys, of course, right? And of course, diarrhea, GI related. And then in terms of decreased level of ionized calcium, we're going to be seeing that secondary to the parathyroid hormone problems. And at the same time, alkalosis. So, what are the signs and symptoms that you're going to see when you have patients that have hypocalcemia? So there are a variety of signs and symptoms, but in this lecture of nursing that makes sense, we're going to talk about the 3 common symptoms that you're going to see. And I initially put cardiovascular sign as actually the first sign that you're going to be seeing when you see hypocalcemia. You're going to see prolonged QT interval. You're going to see bradycardia, really, and symptomatic bradycardia, at the same time symptomatic hypertension. The next thing, I'm sorry, that's my alarm. The next thing is neuromuscular signs and symptoms, and the common one that we're very familiar with are muscle twitches or muscle hyperactivity. And there are 2 common things that we've learned in nursing school. Every now and then you're going to see this in the clinical setting. It's very rare. Like I said, most of the signs and symptoms would be related to the cardiovascular. The first neuromuscular sign would be the Trousseau sign. This is where you're going to have carpal spasm when you put like a blood pressure cuff that's higher than the systolic blood pressure, and you're going to see a little bit of a spasm, or the patient is going to experience that. The other one is Chbostek sign, wherein you try to kind of like stimulate the facial nerve near the ear, and you're going to see facial twitches in there. And of course, GI symptoms, again, you usually see that related to hyperactive vowel sounds, or when we call vowel sounds, normal vowel sounds are what we call borborygmi or borborygmi, however you want to pronounce that, right? But this hypocalcemia, you're going to have really high hyperactive vowel sounds. There are a couple of treatments that you're going to be encountering. You're going to see that the doctors were going to order when you have hypocalcemia. Of course, you're going to give calcium. Either you can give it by the PO route per mouth, or you can give it via IV. The thing about giving it IV, you have to really give it very slow because it can be irritating to the vein. One of the things that you could do when you give calcium slowly in the vein, you really need to watch your EKG monitors, because remember, we have that bradycardia and hypotension. You want to see some changes. You're going to see very quick change when you give calcium chloride. You're going to see a little bit of change when you're going to give calcium gluconate, but you're going to see that normalization of your PQRST, and at the same time normalization of your rate. The other treatment is the administration of aluminum hydroxide, and of course, as I mentioned, calcium gluconate and calcium chloride. Now, between the two, you can give either of the two. Again, as I mentioned, make sure that it's a little slow when you give it. You don't want to give it too fast because it can be irritating to the skin. Now, calcium gluconate is a little slower in terms of the effect compared to calcium chloride. You're going to see the effect immediately with the heart rate. Like I said, it's going to start normalizing the PQRST, and then of course it's going to start normalizing the rate, and at the same time you're going to see changes in your blood pressure. Now your blood pressure is going to start going up when you give these IV supplements when you're treating hypocalcemia. Okay, so as I mentioned at the beginning of this channel, I want to keep my video at least 10 minutes long, so we're actually on the 8-minute period. So I'm gonna stop here, and I'm gonna talk about hypercalcemia in my next video. So have a good day, and I hope you come back.